PMR, and there's been a lot of content that we've been pushing out on the Room Now website. There's a lot more to come. If I could show you the plans for what's coming this month, I think you'd be overwhelmed. But we're just rolling it out week after week, going through all of the interesting points in PMR. I think a disease which we haven't traditionally had the opportunity to talk about much, but I think we need to make room for PMR, hence the slogan for our month. I'm David Liew. I'm a rheumatologist in Melbourne, Australia. I am one of the editorial staff for this month with my colleagues, Dr. Sarah Mackey and Dr. Sebastian Satui. All been working very hard on that with Jack and the whole team. So thank you to all of them. Also, of course, thank you to our sponsor for the whole month, Sanofi, who have really have had no input at all into the content or anything that we're doing, but thank you for their support as well. So also thank you to the people who are joining us live tonight and then also on the replay as well. I know that we have lots of people listen to it throughout the week, throughout the month. So hello to you as well. For you, those of you who are joining us live, don't forget to ask questions. We're always keen to have this discussion. I think when it comes to a discussion like today, which is going to be on steroids and PMR, then I think everyone's had experience and everyone's had all sorts of positive, negative experiences. I think there's a lot of different ways in which people do things. So I'm really looking forward to seeing the questions that come through tonight. Before we go any further though, I am joined by an esteemed panel of 3 people here. So I'm going to get them to introduce themselves, tell us where they're from, who they are, where they're from, and what makes them interested in this area. So I'm going to start with you, Dr. Conway.
Hi everyone, I'm Richard Conway, rheumatologist from Dublin, Ireland. I have an active research interest in PMR and I run a rapid access PMR clinic as well.
Fantastic. Dr. Lally.
Hi, I'm Lindsay Lally from New York, New York. I similarly have been involved in PMR research as well as, an active clinical practice, seeing lots of patients with PMR.
Fantastic. Dr. Yates.
Hello, I'm Max Yates. I'm based in Norwich in England in the United Kingdom. I'm an academic rheumatologist, again with a clinical and research interest in polymild rheumatica. So
these are 3 of the top people in this area. I couldn't ask for a better panel to have this discussion tonight. And actually, I think before we get stuck into it, and we've got the survey results that have come out from yesterday, they're very interesting, worthwhile having a look at. But I'd really love to hear some opening statements from everyone. If I can ask everyone really, sorry, and I've just got a message there, of course, Richard and Max get big kudos for calling in the middle of the night. It's midnight for you, Max, is that right? Yeah. Wide awake, matchsticks, keeping your eyes open. Richard, it's similar. Midnight as well. Yep. So thank you very much for staying awake for us. Nice and sunny here in Melbourne. It's 10 a.m. so I've got no complaints whatsoever. But before we get stuck into it, opening statements, I'd really love to hear from everyone about perhaps their bugbears in a lot goes right in steroids and PMR, a lot goes wrong. I think what's the one thing that makes you passionate? And I guess anger often makes people passionate rather than good things. What's something that makes you passionate about this area, perhaps a bugbear, or maybe something really good about steroids and PMR? Richard, I'll start with you.
Well, I'll go with controversial. I think PMR is one of our most mismanaged conditions in rheumatology, both in diagnosis, but also in the steroid management. And what my main bugbear is people being left on too much steroids and having multiple steroid side effects. And I think we can and should do better than that.
How do you think this has happened, Richard? Because I mean, it seems PMR is one of the few diseases where we just accept people being on long-term steroids. It's probably the rheumatic disease which is most dependent, is the rheumatic disease that's most dependent on long-term steroids. Yeah, how did we get to this point?
I think we have a window of opportunity at the start of PMR to do things right. And if that's missed, and if the patient ends up stuck on whatever amount of steroids and starts getting side effects from that and starts having steroid withdrawal or flares every time they come down. It just turns into a vicious cycle. So I think the key really is doing things right from the start, having a proper plan and trying to get those steroids down, however difficult that may be.
Fantastic. Lindsay, tell me what makes you passionate about steroids and PMR?
I mean, I think we can all attest to how steroid responsive true PMR is. And it is one of those conditions where it's so rewarding as a physician when you see a patient who's been suffering for, months, and they step into your clinic and immediately this is polymyalgia, and that, you're writing that prescription. And by the time, tomorrow comes around, they're going to be feeling, significantly better. And that's when, you get those phone calls about how brilliant you are and how amazing you are. And, that's the really rewarding part of PMR. And then I'll, definitely dovetail back onto what Richard said, and then we start getting into, the phone calls about the high blood pressure and the sugar and I can't sleep and all of the steroid related complications. So I do think there's this very fine line between, managing people appropriately and using steroids smartly with these patients. And then, getting them off the steroids in a responsible way. At a tertiary care center, I see patients who come in for second and third opinions on PMR, and they've been on steroids for, 10 years. And at that point, it's sort of like game over. So I do think, it's our responsibility as rheumatologists to make sure, we're making the diagnosis, right up front. We're getting these patients on appropriate doses of steroids, and then we're getting them off.
I mean, it's so true, that classic paradigm in PMR treatment where the best week is that first week. That's when you're the hero as a clinician. The patient will, walk over hot coals for you, walk over broken glass for you. And then when you get to that 10-year mark, then what have you done to them? What have you done to them? So yeah, I think that's clearly, that I'm sure that resonates with everyone on the call. Max, you did your PhD in steroids and PMR, so you've got a long-standing interest in all of this, worked on it plenty since then as well. Yeah, what makes you passionate about the area?
Well, probably PMR treatment, does vary by country around the world, and particularly within the United Kingdom, where we have a primary care and secondary care kind of interface. Over 70% of people in the United Kingdom are managed exclusively in primary care. And I think we kind of do a disservice both to patients and to our primary care physician colleagues. I guess in the United States, they call them family practitioners, in terms of the amount of information that we give individuals. And often patients will start on steroids. There may be doubts about the diagnosis once we come to review them, but it's quite difficult to unpick that, particularly if it's 10 years down the line. But really, often the patient and the family practitioner are kind of left trying to manage this. And there's a dearth of information in terms of telling them precisely what they should be doing. And, often you hear patients being left essentially to manage their steroids themselves, and yet they haven't had the education about the things to look for, the problems with steroid withdrawal, and the flares that Richard has kind of alighted on, and I think that just leads to a whole load of problems. So it's really kind of getting that education right, and I think traditionally our guidelines haven't really helped. They say that you can be off steroids after a year. We know that's not true for the vast majority of patients. So, it's kind of getting that education, supporting individuals, both the practitioners delivering care and also the patients.
I mean, it is just so easy to write that script for prednisolone or to write the script for steroids, and then all the hard work does come after, really, doesn't it? Yeah. Okay. All right. So we do have some survey results. We sent out a survey yesterday, and thank you all for your response. I'm going to share my slides here. And so you should be able to see that there. PMR and steroids. So this went out. We've had 1 day out there, 299 responses, and good distribution across the world, 57% from the US, but then really representing practice from a number of different places across Europe, South America, Asia and Australia, and a few other different places as well, and amongst there as well. Really great to see that response. Let's have a look and see, though, like you said, Max, about how maybe in amongst all that, the responses have varied in this global response. So the first question we asked people was, how often do you start a new PMR patient on 20 milligrams or more of prednisone? And as you can see there, 58% said 10%, 8% said 20%, and then a third of patients for 6%, and then half for 26.5%. So I'm interested in knowing what the panel thinks about that, and then maybe we'll talk a little bit about what people's standard regimen for steroids and PMR is at the moment. Max, maybe I'll go the reverse order. Max, what do you think about that? Does that surprise you at all?
Probably doesn't surprise me, but I can see a wry smile creeping across particularly Richard's face. And personally, for me, I think most of the time, probably more likely 90% of the time, 15 milligrams of prednisolone is often enough. There are a few patients where you need to go higher than that, but I certainly wouldn't traditionally go for 20 or more. I think that's probably a bit heavy-handed, and the higher the dose, I think the more the problems you're going to end up with. You also have problems of how quickly you're going to taper that. Often these patients are kind of left on a starting dose. It might be 3 weeks, 4 weeks, 6 weeks. It depends on who's kind of started that and how judicious they are in terms of their follow-up and informing their patient what to do next. So yeah, I'm quite surprised that it looks quite heavy in terms of the dosage.
Richard, was that wry smile appropriately attributed there?
Yeah, absolutely. I completely agree with what Max has said. I think for the majority of patients with PMR, 15 milligrams will be enough. You start them on 20 milligrams when they don't need it. That's quite a significant extra amount of cumulative steroids as they get into their treatment. I also think that the 15 milligram dose, I like it as a diagnostic tool almost as well, that the higher you go, the more things that are going to respond to that dose. And if they respond really well to 15 milligrams, that, at least in my mind, kind of supports my clinical impression that PMR is what they have. Whereas if we're on 20, 25, I'm be surprised if most conditions should respond to that.
So Lindsay, Jack tells me that the responses were very similar between an international audience and a US audience. Do you think this reflects practice at the Hospital for Special Surgery, or maybe more broadly across the United States?
I think, I would rarely ever put a patient on more than 20 milligrams of prednisone if I was suspecting PMR. And I agree that then, you start worrying, what are you masking or missing in terms of concurrent GCA or other diagnoses? So I think for the most part, 15 milligram is our standard. I think we want to always individualize to the patient sitting in front of us. So in a patient who's much larger, maybe, starting at the 20 milligram dose. But I also think that this is somewhat surprising in terms of how many people are starting on 20 milligrams or more, because I think the or more is the more worrisome part there. We often see patients who've gotten like a Medrol dose pack by some either internist or the orthopedist or someone. So they're even getting, higher doses that usually, is starting on a, more than 30 milligram prednisone equivalent. They feel better. Then of course the 5 days ends and they're, achy and sore again. And so I do think there's a responsibility for education about, appropriate doses early on, because it certainly matters down the line when you are trying to taper these patients.
Absolutely. The higher you start, it's the longer you have to come down. So there's a question actually, which I think is quite relevant to this. And I guess it comes to this idea of how do we know those patients who are going to need higher doses of steroids? The question from Dr. Raluca has asked about, it relates to something that we talked about last week on Tuesday Night Rheumatology, and that's been in the literature, I think, for the last 12, 18 months, about subclinical GCA and PMR. Some imaging studies have shown that there's quite high rates of subclinical GCA and PMR, maybe 25, 30%, maybe even more than that. Do you think that if that should or might be affecting the way that we dose prednisolone? And so do you think that that's any justification for these higher doses, more than 15 milligrams to start with? Anyone from any thoughts from the group?
I think the sort of rationale, at least in my mind, is if a patient doesn't respond as we would think to the more moderate doses of prednisone, then I do start looking for other issues, including more large vessel concurrent GCA. I think from a lot of the studies that have been reported, where you see this sort of occult or subclinical large vessel involvement in patients who are otherwise presenting with isolated polymyalgia. The problem is we don't really know the clinical outcomes of those patients. And so we don't really know if those patients do require higher doses of steroids or more prolonged courses of steroids, or if are, at increased risk down the line for the aneurysmal changes and the other sequelae of GCA that we, are so attuned to in our sort of more classic GCA patients.
Absolutely. It's very hard to know what those changes mean. Richard, do you, how much weight do you put on these subclinical changes? Do you think that this affects the course of PMR at all? I guess there's a lot that's unknown in this space. These are relatively new insights.
I think we don't really know that at the moment, and I agree with Lindsay completely. I think there's two different issues. There's people who you think of PMR and they actually have GCA, and if you evaluate them properly, you would then come to the conclusion that they have GCA. And then there's this group who, for all the world, have PMR, but you do an ultrasound maybe, and they have some axillary artery halo, and you're not really sure what to do with that. And I think at the moment, certainly my practice is to, if they clinically seem like PMR, treat them like PMR, and absolutely keep an open mind, see what happens down the line. But I don't think we can justify really starting GCA doses of steroids for these patients.
Mm-hmm. So Max, I might ask you, how many, talk to me about the patients that we do need to escalate beyond 15 milligrams a day. I think we've established from this discussion here, we're all starting at 15 milligrams a day, see where that goes from there. Do we have a better sense as to who who might end up being more likely to go to those higher doses? Do we have a sense as to why that might be the case?
Well, I'm sure everyone's kind of seen the patients. I mean, typically in the UK, we do the C-reactive protein, and it can vary enormously. Somebody might only have a CRP of 7, and a really good story for PMR. Other people might have a CRP in the hundreds. And sometimes you think, well, it's going to be those people with a really high CRP. They're the ones that are going to need a prolonged kind of initial starting dose, whether that's 15, instead of starting to reduce that down after 3 or 4 weeks. You might think, well, I might need to continue that for 6 weeks based on their symptoms. But also, I think it's important that we actually check the blood tests. A lot of patients in the United Kingdom, they're giving a story of PMR to their family practitioner who's starting steroids and then not doing the blood tests. And then that makes things very, very difficult. A, in terms of confirming the diagnosis, and B, in terms of looking at the response to treatment. So I think it is worthwhile, particularly if somebody has quite elevated high CRPs, checking blood tests again after a couple of weeks with your starting dose of steroid, and assessing them and seeing how they're responding to the initial starting dose and how their symptoms are improving. And if they've still got residual symptoms, they've still got an elevated CRP, then you might need to think, well, I might need to push it up to 20 milligrams, but also being very careful that you're looking for other differential diagnoses and you're making sure that you're not missing something else.
Absolutely. A bit like what Dr. Paget said last week, this is not, well, be a doctor, but also I think it's really just important for us to remember this is not a set and forget disease. This is not the kind of thing where we can just tell people how their course is going to roll out at the beginning and then just send them to the community. Well, maybe Max, I can ask you on that front in terms of your standard prednisolone weaning protocol. And I know there's variation. It's going to have a look at a little bit of that in a second. What's your approach, and knowing that there's going to be that variation?
So, I mean, I've in a way, because the evidence isn't really there, I've kind of toyed around with different things in patients in a completely, it's not really a scientific way, of giving 15 milligrams for 3 weeks or 4 weeks or 6 weeks. And then seeing if you then come down to the 12.5 for 3 weeks or 4 weeks, and then do your 10 milligrams at 4 or 6 weeks, and seeing if that kind of seems to have any major differences. But at the moment, I can't really say that there are any differences. Of course, it's not a true trial in any sense, so it's very difficult to be able to do that. Other people have also written this dead stop slow regimen where they continue for 10 milligrams. I think it's for about 3 months. For me, that feels a bit too much, and I'd like to try and get people down on their steroids. And of course, if they're flaring, then you need to go back up again. But yeah, I think leaving people on certainly more than sort of 10 milligrams for more than 6 weeks, I think you're really going to start to run into problems. They're going to get adrenal insufficiency. They're going to get steroid withdrawal anyway. They've probably got osteoarthritis. And then trying to unpick those 3 from actual true relapsing polymyalgia rheumatica, it becomes an almost impossible task, particularly as Lindsay said, when you've got your patient who was diagnosed 10 years ago. You're then having to work incredibly hard to try and unpick that and really kind of support the patient, see them regularly, and review them as soon as they start developing new symptoms or worsening symptoms, just to make sure that you're definitely on the right path.
Absolutely. Well, perhaps on that note, I'm going to show, go forward a bit on the slides and show some of the guidelines. And I'd really like to get Richard and Lindsay's thoughts on these. And I guess I'd ask the question, do we have it right? Are we going too fast? Are we going too slow? Is it really hard to say? So what have we got here? These are the British Society of Rheumatology guidelines, BSR guidelines. And so just here on that left-hand side is the most relevant bit. So the BSR guidelines suggest prednisolone 15 for 3 weeks and 12.5 for 3 weeks, then 10 milligrams for 4 to 6 weeks, and then once every 4 to 8 weeks, a reduction by 1 milligram a day at the time, or alternate day reductions. And then the possibility of using IM prednisolone. So this is that approach is similar in the discussion in the ACR provisional classification criteria in the discussion. So that's but different nevertheless. 15 at the predefined protocol in amongst the new diagnosis of PMRs was 15 milligrams a day for weeks 1 to 2 for the first 2 weeks, 12.5 for the next 2 weeks, 10 milligrams a day between weeks 6 to 11, and then going down 10, 7.5, 7.5, and then going down beyond there, knowing that there's very good glucocorticoid responses. And then if you look at the 2015 ULR ACR recommendations, it's firstly, of course, individualized protocol, but then I think we've got it here. So get down to 10 milligrams a day within 4 to 8 weeks, and then decrease it gradually for when you have relapses and then further tapering from there. So I'm interested. That's obviously a lot of variation captured in recommendations, official recommendations and guidelines from learned societies. Lindsay, do you think that's too far? Are we getting it too fast, too slow, or is it hard to say?
I mean, I think even just in what you just showed, there's variability. So maybe too fast, maybe too slow, maybe just right. I don't know Goldilocks, but, you know, I think I usually try to, you know, do that first step down after 2 or 3 weeks. And, you know, some patients who respond very quickly and are very eager to get off the steroids, you know, I do feel like they often push me to do a taper that maybe is, I know is a little too quick. And I know that somewhere, you know, I always have the conversation with patients when I'm setting the expectations about, you know, the probable duration of steroids, but also, you know, that there's nothing written in stone and we can try to taper a little more quickly, but that is probably at the expense of having some flares, which is not the end of the world. We go up a little and then we come back down more slowly. But I think there has to be, you know, the conversation between the patients about, you know, that fine line between controlling disease and using too much steroid. I typically try to get down to 10 milligrams in the first month, and then we'll go down by 1 milligram increments, you know, about every 4 weeks, you know, making adjustments as necessary.
We're going to talk a little bit more about this expectation setting. It's a very pertinent point. Richard, I know that you've got some thoughts on whether this is too fast, too slow, or just right. What do you think?
So I think what we've already shown with the variation in this, and trying, for us as rheumatologists who are interested in PMR, trying to read these guidelines and think through those dose changes in our heads, it's very confusing for us. And I think for patients who don't have our experience, it can be incredibly confusing. And I see huge problems with the steroid regime that's given not being followed accurately for various reasons. Either mistakes are made in the labeling from the pharmacy, mistakes are made with the patients taking the steroids as directed. So I relatively closely follow what the BSR guidelines say, but I take a more pragmatic approach to it and simplify it a bit. So in Ireland, our patients get a month's supply from the pharmacy at any one time. So I try and utilize that and essentially give them the same dose for a month. I don't do anything at 2 or 3 weeks because I think it just gets too confusing. So I give them 15 for a month, 12.5 for a month, 10 for a month, and then down by 1 a month. And as well as the changing steroid doses, obviously with the different strength tablets, they're also changing that in the middle of that. So I think trying to do anything that isn't on the monthly basis where they have to do it themselves is just really asking for trouble. And then obviously we do adjust it and modulate it depending on flares or responses or other things. But I think as a simpler starting protocol that has served me well and led to reduced errors in the following that steroid regime.
And there is something to be said for that simplicity, isn't there? I mean, just I think trying to scrimp on some of these steroids at different points for the 4 weeks versus a month, and that just makes it even more confusing, and all of a sudden patients on longer, more or higher exposures of steroids than we'd like. Well, let's have a look at this, the next survey question, which I think is pertinent to all of that. So we asked in the survey, how long will a patient be on steroids? What do you tell the patient? And I guess we've kept these questions when Jack sends out these surveys, we're deliberately making a little bit vague. We want to see how people respond. And I think it's important to see some of the variation that occurs. So what have we got here? Well, so 34% said one year of steroids, 22 said 2 years, and then 40% said variable as well. So maybe I can ask the group, are we surprised by that? What do we tell patients? Yeah, any thoughts on whether we should be communicating differently with patients? I mean, Lindsay, you kind of talked a bit about that expectation setting. What do you tell patients about how long we should have patients on steroids for?
Yeah, I usually tell patients to expect that it's going to be at least a year. And if we can get them off more quickly, great. And if it runs into, sort of cite some of the data, about 2 or 3 years being the mean duration of steroids. And, I do tend to talk to my patients about some of the reasons that I think people end up on steroids for too long, including sort of hopping back up whenever they have an ache or pain, not being able to discriminate between the arthritic shoulder and the PMR flare, or, every time the CRP or the SED rate, tips up a point, going back up. And so I do think, some of our patients end up on, inappropriately long courses of steroids, or that they're managing it on their own and not seeing, seeing us regularly to help make sure that they're getting down. But I think a year is sort of what I tell most of my patients to expect. And as we approach that year, if they're, still struggling, getting below 5 milligrams, I still encourage them that this is, what is expected, and that the finish line is still we're still gonna reach the finish line eventually.
It's hard to be able to set expectations realistically, but with a sufficient ambition in them, I guess, isn't it?
Yeah, I mean, we don't know. So, I refer to the fact that I left my crystal ball at home, but this is what I would anticipate.
Yeah, absolutely. I mean, part of reflecting that uncertainty to our patients is important. Max, I think that this is something that you've looked at in the variability. Do you think that how should we be communicating this to patients? How should we be expectation setting?
Well, I start off by telling patients that observational data of prescriptions for steroids, both in the United Kingdom and actually around the world, shows that the median duration, so half of patients will be on steroids for 2 years. Now, some people invariably are going to be able to come off faster than that. I've had patients who really wanted to come off steroids and come off after a few months, inside under a year. But most people, it's going to be 1 to 2 years for half, and that means, of course, half of people are going to be on steroids for longer than 2 years. And the further you get out from that, the more difficult it is for those people to be able to come off steroids because of problems with adrenal insufficiency. But word of warning there is that it doesn't necessarily always affect your patient who's been referred to you, who's had steroids for 10 years. It can develop relatively rapidly. I've certainly seen patients who have adrenal insufficiency who've only been on their steroids for 18 months. So, it is something that I think we should be looking out for regularly in our patients.
Absolutely. Okay, well, maybe kind of on that point, I think there's a little bit about in terms of, I think this question was really trying to get an idea about how we go about trying to wean, between how much stability we need before we try and start to wean prednisone. I think you can see there's a lot of variability there. Richard, let me ask you, and I think this probably varies a little bit from the survey question. How long do you have someone on a stable dose of prednisone before you drop them down? Are we going with the 1 month thing because that makes a lot of sense? Have we ever attempted to go faster than that or slower than that?
Yeah, I go with the 1 month thing. It provided they're in remission. I generally don't worry too much about what the SED rate or CRP are once they're in remission. I still generally try and reduce it, bearing in mind that there might be a higher chance of relapse if we do it with a still elevated CRP. But if they're clinically in remission, I'll still pursue that. I don't think we have great data to support the 1 month thing or to refute it either. So as I said, I do that because it's simple. I think we need better studies to look at this to see if some other speed of reducing is better. I mean, and overall, I think the answers to this question are very scary. Like they're almost insane. We have people saying they want people in remission and a normal ESR for 6 months or a year before they even try tapering the steroids. I can't understand that at all.
And I guess it's clearly it varies on the stage of the disease, and I wonder whether, I think some people were wondering about the when people are at stability on lower doses and trying to reduce it down, but still then, I mean, the fact that we are basically tolerating keeping people on a standard dose and that's routine practice, I think is probably unlike a lot of other diseases in rheumatology, perhaps any other disease. Lindsay, Max, any kind of other thoughts on whether how strongly we should wait, we should ensure that there's remission or wait for remission before trying to wean to the next dose of prednisolone?
Yeah, I mean, I think it's a matter of weeks. Seeing the patient clinically doing well before you drop down to the next step. So I think when we start talking about months and years, I would agree with Richard. It doesn't really, go with what I think we do clinically. So maybe there was some misinterpretation of this, because I can't imagine people really waiting for a year before stepping down the steroids. We don't do that with any of our rheumatic diseases.
Absolutely. Now keep the questions coming through on the live ones. We've got a few there which we will definitely get to, but please keep them coming. So maybe I think relevant to that question, which is I think something that got alluded to there by Richard, was really about trying to figure out, I think if remission is one side of things and we're relying on symptoms, how do we go about detecting flares, and how do we deal with flares, knowing as well sometimes people do get this glucocorticoid withdrawal syndrome. They do get these aches and pains which aren't inflammatory and aren't overt tertiary adrenal insufficiency. How do we navigate that? So I think, Max, you brought this up first. How do you get through that in clinical practice?
I mean, really, it's asking the patient in terms of what those symptoms are, and checking with them that are they similar to when they first had their PMR? Is it affecting their shoulders and their hips? Is it stiffness that is dependent on activity, in terms of the more they try and reach in terms of the extremes of movement, the worse it is in terms of the stiffness and the pain? Or are they actually saying, well, oh no, I developed back pain, or I've got a pain in my foot? Because a lot of the time, I think patients sometimes have got into this cycle where they think that as Richard said, any symptom that they've got is due to their PMR, and they just bump their steroids up. So it's really about trying to clarify what do they actually mean by those symptoms. And of course, the adrenal insufficiency and steroid withdrawal syndrome, that kind of general malaise, not feeling quite right, bit out of sorts, that probably isn't enough to say, that's going to be their PMR coming back. So it's just making sure that you're checking with your patients, making sure that you're educating them about all the potential sort of differentials it could be. And it's worthwhile stating that you don't always necessarily have to increase the steroid dose. You might want to pause and wait and see maybe 1 to 2 weeks and see if it will go away before making a decision about what you're doing with the steroids. Because that, not increasing or decreasing is still taking a decision in terms of their management.
Yeah, Richard, Lindsay, do either of you have kind of thoughts on how you talk to patients about, do either of you talk to patients proactively about how to manage those that steroid withdrawal syndrome, about what a flare might be versus not, or do you wait for that kind of thing to happen and deal with it once it occurs? Richard.
I try to be, oh, sorry. Go ahead.
Oh, Lindsay, go. Yeah, absolutely.
I mean, I agree with Max. I try to be proactive in talking to the patients and sort of, especially as we're getting to those sub, 7 milligram type doses that, with each step down, you may feel a little achy and just generally blah for, the first few days. If it lasts more than a few days, let me know, but please don't go up on your steroids before, communicating with me so we can really, figure out if this is a steroid withdrawal, if this is a true flare, if something else is going on. Even now with viral infections, COVID, non-COVID, patients want to, the minute they start to ache or not quite feel right, they're blaming their PMR, and if they, they would, jump back up on the steroids. And I think, sort of encouraging an open dialogue and educating the patients really helps to prevent, a lot of that yo-yoing.
Absolutely. I'm interested we've got a question here from Dr. Mittu, who asks about the role of NSAIDs to assist with dose reduction of prednisone. And I guess this idea that maybe if there are some arthralgias and myalgias, they're not overtly inflammatory, and it's about trying to navigate the symptoms. What do we think about that? Richard, what do you think about NSAID? Is that something A, that you use, and B, what do you think about it more broadly?
Yeah, it's not something I generally use for PMR symptoms. I suppose you could consider it for osteoarthritis symptoms that are re-emerging as the steroids come down, which often does happen. It always makes me a little bit uncomfortable, however, having NSAIDs and steroids going into somebody at the same time and the potential side effect profile of that. So it's something I would very rarely do. I would generally choose to do something else, whatever that may be, whether injecting an osteoarthritic joint, or if their PMR really is flaring again, then I think they either need temporarily more steroid or they need a more targeted disease modifying or biologic agent.
We really would benefit from better biomarkers and better ways of picking up flares, wouldn't we? Especially ones that are maybe less, which are less IL-6 dependent, and maybe might be less affected directly by treatment, might represent that inflammation. I think that's in the scope for the future. Let me just move to the next slide, because I think we've got some more discussion, and I think we can come back a little bit to about what the future of steroid might be. So getting to these flares between 5 to 7.5, like Lindsay was talking about, what do we do to respond to those flares? Are we going up? How much are we going up? And so in amongst the options here, and I think we forced people's hand a little bit with multiple choice. I'm sure that there would be 20 answers if we could give people a short answer response. But 64, so between 5 to 7.5, if there's a flare, then 64 said increase to 10%. 30% said add a steroid tapering drug. And then much smaller percentages said double the dose, and then backed all the way to 15. Lindsay, how do you tend to respond when you get, especially when you get into those below 7.5 flares? How much are you going up by? Are you going back up to 10? Are you going up by a milligram? Are you waiting it out a little bit? How do you respond?
Yeah, I mean, I think it really does depend. So I would probably have, voted for none of the above on this one. But I do think for the most part, I usually try to increase by 1 or 2 milligrams and see how the patient responds. And if they get better, great. And if they're still achy, then get back up to 10. I think it's very, very rare that I go all the way back up to 15 once a patient has gotten, down to these low doses. And I guess I would say, with regard to adding a steroid sparing drug, I think it depends, how many times you've been through this cycle and what the other toxicities the patient has developed are. So if I can't get a patient below 7.5 milligrams and I've tried all the head fakes, switching to a different formulation, maybe, dividing the dose, or any of those sort of things that are not in the guidelines, but I think clinically we all have our little tricks that sometimes can be helpful. Then I will, start thinking about if another agent is necessary, but I definitely give patients a couple of tries, to get down at this level when they flare. And I'm usually pretty conservative with how much I increase to try to recapture the symptoms.
Absolutely. Well, Richard, I just want to ask you here, we've got some more questions flowing in. So what about we talked about injecting osteoarthritic joints. What about shoulder and hip injections to complement oral steroids and taper, or in lieu of oral steroids when oral not tolerated? And I think this is probably more about when we think there might be a bit of an inflammatory component. We know subacromial bursitis, trochanteric bursitis may well be components of, they certainly are involved in active PMR. There's inflammation at those sites. Is there a role for steroid injections at those sites to try and dampen down some of the inflammatory features of PMR?
It's a tricky question, and again, I'm not sure we know the answer. I do it a lot for non-inflammatory or non-PMR related stuff, so rotator cuff tendinopathies, gluteal tendinopathies that are emerging and worsened by the oral steroids as we're coming down. I think I occasionally do it for things I think really are PMR. It does work in that it provides at least temporary symptomatic relief. My concern with it more is that in the longer term, it's not actually helping us get to an end point, that it'll work for a few months, but then it'll just come back because we've persisted in reducing the steroids. We haven't really correctly addressed the underlying disease pathogenesis by trying to suppress it more fully with an immunosuppressive, whether that be steroids or something else systemically. So yeah, I do it, but mainly for mechanical stuff.
Well, I guess, yeah, this idea that PMR is a systemic disease. If there are focal points of inflammation, that it does has to be dealt with like that. More questions here, and I'm going to try and fire through some of these. Max, I might ask you a little bit about this question here. When we get our patients into the 2 or 3 milligram dose, it's from Anonymous, by the way. When we get our patients into the 2 to 3 milligram dose range after, let's say, a year, how much adrenal suppression actually exists? I'm interested in your thoughts on this.
Well, tricky one, that one, isn't it? Because I'm not sure anyone can give you a precise estimate for the number of people that actually have adrenal insufficiency. But it's going to be some people. By the time we got to 2 or 3, I mean, you hope that you're on the end to the finish there. Really, often it's people who are still kind of flirting around 5, 6, 7, something like that. By the time you're getting to 2 and 3, you usually going to be okay. That, of course, there are going to be some people where they can't. But really, what I do is that once the patient has come down to 5 milligrams of oral prednisolone, I get them to do a 9 a.m. cortisol on during the morning, of course, at 9 a.m. Without taking that day's dose of steroid until they've had their blood drawn, and then they can take their dose of steroid. And then based on that, you might need to do a short synaptin test, or you might actually have confirmed adrenal insufficiency, in which case it's going to be, virtually impossible, particularly in the shorter term, for them to come off their steroids. They need to be educated about sick day rules and all of those sorts of things, and have a steroid card, register with emergency services, and etc. But when I was at medical school, the physiological dose of prednisolone was 7.5 milligrams. It's now come down to 5. There was a paper, I think, about 6 months ago that said actually it's somewhere between 3 to 5, depending on the individual. So yeah, it's still a moving beast, to try and track down really and tackle.
Mm-hmm. So we've got a couple more survey questions, but I do want to talk a bit about preventative measures. But before we go on to that, I just want to ask the group, do we ever feel like it's acceptable to get stuck on a dose of steroid? I think we have these patients who say they're at maybe 4, 5, 6 milligrams, and every time they go down, they seem to get a recurrence of relatively convincing symptoms. How do we find that acceptable? And I guess, has that answer changed in recent times now that we've got potentially therapeutic options? Richard, let me ask you first.
Absolutely. This happens all the time that patients will get stuck on a certain amount of steroid. And I think traditionally because of a lack of other options which have proven to be effective, we often accepted doses as certainly 5 milligrams or less. Some people would have accepted even slightly higher than that, but that always made me a bit uncomfortable. I think it probably should be changing, or at least we should be reconsidering it now that we have clearly proven effective agents in interleukin-6 inhibitors, that maybe that would be preferable to staying on 5 milligrams of prednisolone. I think it's something that really needs to be discussed with the patient as well, because you are weighing up two different options, a little bit of long-term steroid against a weekly injection, potentially forever, and which of those their preference is.
Now, Lindsay, I remember a few years ago, and probably more than a few years ago, reading your phase 2A study of tocilizumab in ANR and thinking, oh, that's a neat piece of work there. That's very interesting. And now, of course, we've got the SAFA study, which came out last week. Also, obviously on a very different scale, but now we've got these IL-6 targeting options. What kind of dose of prednisolone would you have to be stuck on, do you think, to justify in your mind, in your practice, and then maybe where we might go? What kind of dose would warrant looking at a medicine like sarilumab or potentially other parts of the world, tocilizumab?
Yeah, I think I've, for a long time, believed that IL-6 inhibitors, certainly have a role in, at least management of some of our PMR patients. And, I'm very happy that we now have, more definitive data and, regulatory approval to at least try to use some of these therapies. In my mind, I will again sort of defer to the patient sitting in front of me, and so it really does depend on what other comorbidities the patient has developed, and what we're juggling. But really, if a patient 5 milligrams is sort of my my marker, that if I can't, if a patient is on 5 or less, then I'm usually pretty comfortable keeping them on the prednisone, for longer periods of time. But if they're really having a hard time getting, to that 5 milligram mark, I think it certainly at least warrants discussion about alternative agents. And, I certainly agree, there are risks associated with IL-6 inhibitors, and we certainly have to have these informed conversations with our patients. But I definitely think that, there's going to be, increasing conversations in my clinic, in those patients where, they're between that 5 and 10 over and over again. And you sort of feel like it keeps being Groundhog's Day.
Absolutely. I do want to get on to vitamin D and calcium, and we're going to talk about new therapeutics next week, but had a few questions about methotrexate, other agents. Max, I might ask you first, methotrexate in this situation, what's your answer to that? What kind of dose of prednisolone have you thought about using methotrexate in the past? Is there still going to be a role going forward for methotrexate?
Potentially. We're doing a clinical trial where we're giving methotrexate to people who are relapsing with their PMR. In terms of what dose, with methotrexate, I think it's probably a bit safer potentially than biologic agents. That might be a controversial thing to say, but I think it kind of depends on the patient really. If you've got a patient who's adamant they want to come off steroids, they've not got adrenal insufficiency to warrant being on long-term steroid, then I think we should do everything we can to try and assist that patient to be able to come off their steroids. So if that means that you're having to use methotrexate or lutamide and they're only on 3 milligrams of prednisolone, then as long as you've had that discussion with them up front and you've informed them, I think then that's a reasonable thing to try and do.
Richard, let me ask you, with some other mechanisms of action that might come through, JAK inhibitors, for example, do you think that that threshold might change in terms of what dose of prednisolone would trigger off the introduction of a steroid-sparing agent?
I'm not sure it will. I mean, I think JAK inhibitors they've got to work because they're going to inhibit IL-6, so they are going to work. That JAK inhibitors potentially have more side effects, especially in this sort of patient population, than an IL-6 agent would. So I think, if anything, the threshold for starting a JAK, if an IL-6 has failed, would be higher. But I think there's lots of promising agents out there, IL-17 inhibitors as well, being looked at, and so yeah, the future is bright for PMR, I think.
It is. Now, I want to put up one of the last survey questions here before I ask a bigger, broader question at the end. So new PMR patients starting prednisone, do you start calcium and vitamin D? And we had big responses. 68% said they start all patients on calcium and vitamin D, and then smaller proportions for more targeted ways. Lindsay, I might actually just ask the group, and whoever feels passionately about this, do you think that we're sufficiently managing complications in advance of them happening for prednisolone and PMR, for prednisone and PMR?
I don't know if I feel passionately about this, and I do think we've done a better job, than maybe we used to historically. But I still certainly think that, there are definitely patients who are, losing significant amount of vertebral bone density in the first few months. And, we may not be, I sometimes, I give them the order for the DEX and tell them to take vitamin D, but, may not be as aggressive with anti-resorptive agents. I think we still see patients with hypertension, with, new onset diabetes, even at these more moderate doses. So I think we're, as a, rheumatologist in general, I think we're much more aware and proactive, but that often, means giving patients, 6 prescriptions, walking out the door so they can take the prednisone, and that can sometimes be a tough sell.
Absolutely. Max, can I just ask you, in terms of the UK data, do you think that we're doing okay in terms of prevention, or are we lacking?
Oh no, it's going to be atrocious, isn't it? So yeah, I mean, people have looked at all prescriptions of steroid, irrespective of indication, and I think, co-prescription, whether that's thinking about gastric protection with a PPI inhibitor, whether that's bone protection, whether you're just using Adcal, or whether you're going forward and giving them bisphosphonates, it's very low, very low.
Yeah. I think brings me on to kind of the broader big question, which relates to a question that Dr. DeQuet's got in the Q&A. And I might ask Richard first, but I'll ask all three of you. It's really, therapeutics are changing quickly in this space. We've changed quickly in this space. Now we've got the FDA approval for sarilumab, for PMR. There's potentially other agents that may well be on the way in the future. And we're clearly not doing as well as we should do as far as steroid management, prevention of steroid-related morbidity is concerned. Is now the time for new recommendations? What should we be doing about this more broadly? Richard, what do you think?
I think it is. I think we need updated recommendations in line with the emerging data that's coming along. And I think recommendations are great and important, and we need those as our baseline. But I think we also need to be more fluid in what we're doing. We can't always be waiting for the recommendations to catch up. That process because of the nature of it, always takes time. It can't be constantly updated, at least with the current methodology. So I think we need to be a little bit more proactive and not. We can use the guidelines as a starting point, but we need to be interpreting the new data ourselves as well and incorporating that in our clinical practice.
Absolutely. Lindsay, what do you think?
Yeah, no, I agree with Richard 100%. I think certainly we need new guidelines. We have, new therapies, emerging data, even with current guidelines, it looks like, if we go by this survey, lots of steroids are being used in high doses, even up front. And, getting these patients into the, rheumatology office as, quickly as possible, and then having, our ability to follow them through, I think is really crucial.
Max, what do you think?
Yeah, I'm co-chairing the update for the British guidelines. So the systematic literature review is due to start in February. So we'll have some new trials to look at, which is going to be great.
Well, it sounds like with all the action that's going on, now's the time for us to take some action. I'm glad that we've had this international panel here today, because I think clearly we're going to need better approaches. Now's the time to act. And without sounding too corny about this, maybe now is time to make room for PMR. So on that note, we've run a little 2 minutes over time, but thank you everyone for sticking around. Thank you for all of you who've been listening for sticking in there. Thank you to our three panelists tonight, Doctors Conway, Lally, and Yates, for their enormous insight. And then next week, we've got steroid-sparing therapy that Dr. Sebastian Satui will be leading a very interesting discussion on. So don't miss that. That's next Tuesday night rheumatology. Thank you so much, everyone, for dialing in.